So, good morning, everyone. Today's topic is about the pathophysiology and management of raised ICP and cerebral edema. And then we'll try to devise an institutional protocol we can use in our ICUs. So, what is the normal ICP? It ranges from 7 to 15 millimeters of mercury or 10 to 20 centimeters of water. The thing is, it's always a range because it can fluctuate with day-to-day activities. So, suppose we are sneezing or coughing or anything that produces a valsalva-like thing, we can have an increase in transient increase in ICP. So if we look to this picture here, this shows a normal ICP tracings. There are three waves here, this P1, P2, and P3. So it is similar to our arterial pulse itself. The P1 represents the arterial pulse from the choroid plexus. P2 is related to the cerebral compliance, and P3 is a dicrotic notch, which is related to the aortic valve closure. So this what I've shown here is a normal ICP tracing. So here the P1 is higher than the P2. What happens in a raised ICP is that this cerebral compliance decreases. So this P2 comes higher up actually. So when the P2 is higher than P1, that is normally the pattern we see when there's a raised ICP. So in addition to this normal 10 to 20, suppose the ICP is persistently above 27 to 34 centimeters of water, that is said to be associated with poor neurological outcomes. So what is the importance of looking at this ICP? So it is based on this formula, that is CPP is equal to mean arterial pressure minus ICP. So what it means is that for a given mean arterial pressure, suppose the ICP is high, that means the cerebral perfusion pressure will be lower. So this is very important for us because the cerebral perfusion pressure might be the only driving force in many cases. Example like in stroke, when there are collaterals, these collaterals do not really have the ability for auto-regulation. So all this perfusion in these collaterals will be dependent on the pressure. So if the cerebral perfusion pressure is low, that means this perfusion in all those penumbra regions might also get reduced. That is why it is important in all these cases to maintain the ICP to a lower value so that the cerebral perfusion pressure is not affected. So this is the importance of ICP and its practical uses. So again, this is something which we are all familiar with, the Monroe-Kelly doctrine. So within the skull, we have the brain, CSF, and blood. All of this have their own volumes. Approximately 1,400 ml for brain volume and 150 ml each for blood and CSF. So if one of this expands, it is at the expense of one of the other two. So this is the basic idea for raised ICP. So suppose there is an increase in the blood volume or an increase in CSF volume or an increase in the brain volume. Any of this can lead to an increase in the ICP. So we will look into the different causes based on the same approach. So increased blood volume means either it can be an increased arterial inflow or a decreased venous outflow. An increased CSF volume can be due to an increased overproduction of CSF or a poor reabsorption of CSF. And in brain parenchyma, that's the one we are most worried about. It's either due to maybe due to a space occupying lesion like a tumor, or it can be due to the brain edema swelling, which is called as brain edema, which can be of three types: cytotoxic, vasogenic, or interstitial, which you will see, which we will see in the subsequent slides. So, the different types of brain edema, cytotoxic, vasogenic, and interstitial. We'll go into the details of that in the coming slides. So regarding blood volume, when there is a vasodilatation, obviously there will be increased blood flow to the brain, and that will increase in the blood pool, and that can raise the ICP. This is seen when there is use of vasodilators or hypercapnia. It's also been reported in acidosis and severe hypoxemia. Similarly, when there is a venous obstruction, again the total amount of blood within the brain increases. This is seen in conditions like IJV obstruction, or suppose it's a mechanically ventilated patient, we're giving too much of PEEP. So this positive end expiratory pressure, if we give it too much PEEP, positive end expiratory pressure. So if we give too much of PEEP, again the venous return can be impaired, so increasing the blood volume. So this becomes more important in a critical care situation because we are trying multiple ways to control our ICP. control the ICP. So all these small factors play an important role, and it is important to understand this physiology here. So secondly, secondly, the similar situation can occur when there is increase of CSF volume within the brain. So it can either be due to an increased overproduction or poor drainage as in obstructive hydrocephalus. And most importantly is the brain parenchymal issues. As I told, it can be directly due to a space occupying lesion such as a malignant or non-malignant tumor, or due to brain swelling, which is the edemas, which we will discuss later on. So having said all this, what are the common situations we encounter in our day-to-day practice? So the most common neurological cause we see is acute stroke. Moderate size to large core infarcts invariably have some degree of brain edema, and that is one of the most common causes. The other causes include infective ones such as meningoencephalitis and abscess, CVTs, and large demyelinating lesions such as tumefactive demyelination and ADAM. Also, there are neurosurgical causes which don't usually present to us, but it's worthwhile to know, such as head trauma, obstructive hydrocephalus, and brain tumors. There are IAH also. The other medical causes include metabolic derangements, such as acute metabolic derangements, such as decay or hepatic encephalopathy or hyperammonemia, and other causes such as eclampsia or malignant hypertension. These are all causes which can all lead to raised ICP. Now we will see what the mechanism of these edemas are. The basic one is cytotoxic edema. Before that, we know that the function of the sodium potassium pump is to maintain sodium outside the cell and potassium inside the cell. For every 3 sodium it pushes out of the cell, it takes 2 potassium inside. Now, suppose there's a stroke, there is ischemia, there is energy failure. So the pump stops working. So what happens is the sodium keeps accumulating within the cell, and as a result of it, the surrounding water comes into the cell and the cell swells up. So this is what happens in a cytotoxic edema.
So intracellular compartment will become hyperosphere, which will divide water from the decision. Neurons will swell up.
So in the end, the neurons will swell up, and this is what we see as diffusion restriction in the MRI. An important aspect to remember here is that the blood-brain barrier is intact, and this cytotoxic edema, it can involve the gray and white matter, but it's mostly seen in the gray matter. So as I said, it is classically seen in the early stages of stroke. It can also be seen in postictal state and traumatic brain injuries. In contrast to this is a vasogenic edema. It is an extracellular edema. What happens is it is seen in conditions like tumors or abscesses where there is disruption of the blood-brain barrier. So when the tissue damage gets extends, when the edema extends and there's tissue damage, it leads to disruption of the blood-brain barrier. So once this blood-brain barrier gets destroyed, there is leakage of all these ions and proteins or all osmotically active substances into the extravascular space, which draws in water to this interstitium. So this is what is called as vasogenic edema, and it's usually seen involving the white matter, and it is seen in brain tumors and abscesses. Again, the third type is called interstitial edema. It is somewhat related to vasogenic edema. It is also an extracellular edema. In patients with hydrocephalus, when there is significant hydrocephalus, there is said to be outflow CSF from the ventricles to the interstitial areas of the brain involving the white matter. That is sweepage.
Sweepage of the fluid to
So this edema is seen periventricularly, and it is due to transependymal sweepage of the fluid from the ventricle. And finally, we have osmotic edema. Again, this is similar to our cytotoxic edema. It is seen in acute derangements of osmolarity, such as hyponatremia or DKA, where the cell pulls water from the surrounding areas and the cell swells up. It's also seen in dialysis setting also. So these are the common types of edema. So in addition to this edema, we should also be familiar with what are the features of herniation. So the common ones we encounter are our subfalcine herniation or uncal herniation or a central herniation. So in a subfalcine herniation, one of the complications we can anticipate is the compression of the anterior cerebral artery. in an uncle herniation, before that, who are the patients who are more susceptible to an uncle herniation? Suppose there is
herniation happens if there is a large place that is already higher than the
temporary.
brain of part. That's the first thing. But uncle herniation happens, something happens with the
Temporal.
lower down.
So suppose we have a patient who is having some pathology involving the temporal lobe, and suppose it's a young patient, there's not much brain atrophy, they're at maximum risk for having an ankle herniation. So it can have PCA compression. In addition, the third nerve can be compressed on the same side, resulting in ipsilateral mydriasis. And also, when this herniation occurs on one side, the cerebral peduncles on the opposite side can get compressed onto the tentorium, which can result in hemiparesis on the same side of the lesion, which is called as Kernohan's-Notch phenomenon.
Maybe there are most of the situations where patients require ICP management or brain edema management. We also have this kind of a compartment syndrome happening inside the brain. So an understanding of this kind of herniation syndrome is also important whenever you are managing a patient with a brain edema.
And thirdly is the central herniation. So when all this herniation involves the diencephalon, the most striking feature we are going to get is the depressed sensorium. So that is why it is always important to check the GCS and all frequently in such patients. So
the previous slide, the central herniation happens when something is base of the brain technology is a positive positivity. It will push up through the tentoric cerebellum. You can put the picture of the tentoric cerebellum.
tentorium cerebellum, from there it goes up.
So the same thing potentially happens when there is a massive cerebellar involvement, obstructive ventricular. You are looking at EVD.
Reversal herniation.
Okay. And the infratentorium is slow down. So it will suddenly lead on to upward central herniation with the deceleration. So we have to be a situation where the neurosurgical interventions need to be careful and calculated. Similarly, downward herniation also can happen. They're crowding it rather than that. The posterior also, whenever there is something inflammatory, then depending upon the situation, can either upward or centrally downward.
So we saw the mechanisms for raised ICP. We'll look at the same mechanisms for the potential treatment options also. Suppose there is the ICP increases due to involvement of the brain parenchyma. The first and foremost thing which we can do in most cases is our osmotherapy. As we saw earlier, when the cells swell up with water, if we increase the hypertonicity of the blood, all this water goes back into the blood. So that is the basis of our osmotherapy. We'll come to the details later on.
Manipulating the osmotic gradients across the cellular brain, by which we can either the across the cellular brain or between the interstitial and the blood vessel to control the edema. Okay, so manipulation of the osmotic gradient across the membrane, that is what we are doing with osmotherapy.
And suppose there is a mass lesion, suppose it's a tumor, surgery for removal of the mass is definitely one of the best treatment options. And suppose if it's a stroke, we cannot remove the lesion, we can go for a surgical decompression. And in selected situations, we can use steroids or diuretics also. So these are the treatment options when the brain parenchyma is a reason for ICP increase. Suppose it's due to an increase in CSF volume, we can try our options like EVD, extraventricular drain or third ventriculostomy. As Sir said, when we do this drain in a patient who is having a full posterior fossa, we should always take care. And we should predict whether there's a risk for reverse herniation and all, and it should be done properly. Thirdly, when the involvement is of the blood volume, again, as I told, it is either due to an increased arterial inflow or a reduced venous outflow. So to improve the venous outflow, what we can do is simple measures like just elevate the head end of the patient, keep the head in the midline, and as I said earlier, avoid unnecessary PEEP. All this can improve the venous outflow and thereby decreasing the blood volume within the brain. Thirdly, to decrease the arterial flow, we can either give a vasoconstriction, that is the concept behind hyperventilation, or we can reduce the cerebral oxygen demand. So that is what is tried with all this sedation, burst suppression, and barbiturate coma. What we try to do is decrease the cerebral oxygen demand, thereby reducing the cerebral blood flow, arterial flow. And also, if there are seizures, also it can increase the cerebral oxygen demand. Hence, it is always important to treat any seizures if there are any.
child usually have something like there are three components within the international compartment. Brain stem, the blood, and the CSF. So how we could manipulate each of these components to control the egg. Like that we have to come. So it will stay there.
So having seen all these potential treatment options, so which is the one that is ideal for each patient? So it's not a very easy question, like for everyone we can do this, for everyone we have to give this osmotherapy this long, for everyone we have to go for decompression. It's not always easy. Thing is, there are multiple factors we have to consider. So I'll explain this with examples. We should choose the best approach considering what is underlying neurological disorder. Suppose it is a stroke or a tumor edema, the osmotherapy and whether we to give steroids all differ. For a stroke edema, we usually give a hyperosmolar therapy and steroids are usually contraindicated. Whereas in a vasogenic tumor edema, definitely there is a role for steroids. And also the stage of presentation and how fast we need to correct also varies.
You know the present theory, for example, a tumor edema and a stroke-related problem. So we know the natural history, the blood picture. The next order today is how it's going to behave. Then we know a video on that is how it's going to behave. So we should have some picture in mind as to an ICP with how does it happen in the grand edema. It's keeping on its way, and the resolution will happen for how many days. So we should have an idea in mind. So this can sometimes get generated by MRI transformation. Then the graph is pushed again. So again, you will have a picture. The thinking is a delay for 1 or 2 days, and the resolution will be slower. The hematoma ICP will get this acute hematoma. Then the hematoma related edema will come slowly. And what they usually is a 3-4 days, and the resolution happens slowly. So for every pathology, the buildup of edema and the resolution will take a different flow. So you should keep in mind. For daily, what is going to happen? Next day, what potentially would happen to this patient? So that you should have in mind.
Also, the stage of presentation and how fast we need to correct it also varies. Suppose we are seeing a stroke on the first day, and if it's a large core stroke, suppose the collaterals are poor and it's a younger patient, you can logically assume that there is a very high risk of transforming into a malignant cerebral edema. In that cases, we can initiate osmotherapy at the earliest itself. However, we don't need to aggressively correct it at the initial point itself. In contrast to a situation where there is an impending brain edema or impending uncal herniation, in these cases, we need to act faster. So the stage of presentation and how fast we need to correct also varies in choosing the right approach. Also, the hemodynamic status also has to be considered. Suppose a patient is having underlying cardiac issues where there is risk of heart failure, we may not always be wise to go with hypertonic saline initially. Also, when we give mannitol, there is always a risk for initial decompensation. So in such cases, we may have to tailor our therapy. Maybe it has a role for diuretics in such situations. And all the medical comorbidities, such as maybe there are endocrine or renal issues which may interfere with our osmotherapy, all should be considered. And concurrent medications such as
You need to highlight here, heart failure, or chronic theory, or chronic beginning. Stay clear with your treatment strategies.
And concurrent medications also. Suppose we are giving hypertonic saline as well as mannitol together. Mannitol can also result in urinary loss of sodium. So our correction may not always be adequate. And there are many drugs that can cause SIADH also. So in such situations, always we have to see holistically and see what all are the multiple factors we need to address before choosing the correct therapy. So this is one such algorithm which was proposed by the Emergency Neurological Life Support Group. So they have graded this approaches into tier 0, 1, 2, 3 measures. So tier 0 are our basic approaches such as head and elevation, neck at the center, avoid unnecessary people. So we'll look into all these measures in the subsequent slides. So we'll see with the help of a case. So this is the first case. It's a 34-year-old lady with a prior history of ACI minor stroke, which improved with 0 deficits, now presented with an acute onset left hemiparesis, noticed 5 hours ago. On examination, the GCS was full, pupils were equal and had an NIHS of 16, and an MR aspects of 3 was there. there was pairing of the M3, M4, and M6, and angio showed an right M1 occlusion. So in this case, so is this patient at risk for progression for malignant cerebral edema? So how exactly does edema occur in a stroke? Within minutes of ischemic injury, as I said earlier, there is energy failure followed by failure of the sodium potassium pump, which results in sodium accumulation within the cell and water subsequently entering the cell. Cell swells up. This is called cytotoxic edema. Later on, as the edema progresses, there is tissue ischemia, disruption of the blood-brain barrier. So all these osmotically active proteins and fluid falls from this cells into the intravascular space, and that attracts water. So there is water in the interstitial spaces. This is called vasogenic edema. So can we predict who all goes for a malignant cerebral edema? This Kastner index was the initial scoring system that was developed back in 2001. So this was what we were using for a long time also. When the CT involvement is more than 50% of the MC territory, that is when we used to say the patient is having a malignant cerebral edema. Nowadays, our understanding has changed. We know that many other factors also play a role. There's this MB score is a malignant brain edema score. So they factor into it the aspects, the NIHS, and the collateral status and the revascularization status also. This collateral status is one of the emerging new topics. So the hypothesis is that suppose the collaterals are intact, that means the perfusion of the penumbra regions will be slightly better compared to a patient who has poor collaterals. So the penumbra ischemia will be comparatively better. So as a result, the progression of these areas for developing edema will be reduced. So patient who's having a better collaterals will have a slightly reduced risk for having progression of edema also. So anyway, these are all the scoring systems. Coming to the approach to management. So for that patient, what all can be done? What are the general measures? These are the questions we.
Are you going to describe management stroke?
For this case, we're describing in stroke. So acute. So with regard to the patient I just showed, so what is the approach to management? What are the general measures we can do? How to initiate hyperosmolar therapy? When to go for surgical management? And we also look at the role of the other interventions like hyperventilation, hypothermia, steroids, and barbiturates. So first of all, the physical maneuvers like head and elevation. As I said earlier, it is to ease the venous outflow, so that if the venous outflow is increased, the total blood in the brain reduces and it reduces the ICP. So there has been evidence for more than 30 years that head and elevation reduces the ICP without significantly reducing the cerebral perfusion pressure. And what they say is for every 10-degree increase in head and elevation, the ICP decreased by 1 millimeter of mercury and the cerebral perfusion pressure decreased by 2 to 3 millimeters of mercury. So we cannot go on indefinitely increasing the head and elevation because the CPP will fall. We have to make sure that the CPP is maintained to at least 60 millimeters of mercury. And for a head and elevation, up to 30 degrees is recommended and not more than 45 degrees. So this is with regard to head and elevation.
There are two situations. Before eliminating, there are perfusion pressure in the mouth. And when you flat and then the venous or the so to improve the venous outflow, the best goes to the base without compromising the central perfusion. On an average, 30 degree is ideal.
So next, coming to fluid management, again, both ends have its own issues. Suppose we severely give the patient a lot of fluids, it can result in a lot of dilution. It can interfere with our osmotherapy. And on the other hand, if it severely volume restrict the patient, that can affect the end organ perfusion also. So patients with raised ICP, the current recommendation is that they need not be severely fluid restricted, and it's ideal to keep them euvolemic. And regarding osmolarity, it is best to keep it between normo to a slightly hyperosmolar state. And what is recommended is somewhere between 295 and 305 milliosmoles. And they say to avoid free water, including D5 and half NS. And regarding whether to give dextrose, 5% dextrose and half NS. Regarding the use of colloids versus crystalloids, as of now, there is insufficient data whether which is superior. But there was this one study, which is a SAFE study, which evaluated the use of albumin in traumatic brain injury, and that was shown to have increased mortality. However, we don't have subsequent studies or data regarding which is better.
So, because we need that how much of fluid it is allowed over 24 hours. For which we need to have an idea about what is the normal daily requirement. Average. Because any other work is together on the program. Or it has to be minimum fluid requirement to remove the waste products of the food for an average. You have to clearly write as to text the different outlets of food around which take out for that patient. But the point of utilization, status. Something they should have to take to that hospital, the hospital, and coming out with the specialist of the between. That's what they can take up. If whether the patient is behaving from the only week or all, don't know other form of utilization, something is there. And on an average, the daily requirement of water to excrete of the normal waste products in the given body of about 500. So the GA was with 2 products. And reflected fact that that's still between about the 324. And because of your metabolism, you will produce water inside the body. That is around 2 to 3 PM. So putting everything together for an average, and that is required, we take of 1,400 per day. If the patient, you have to keep in mind, 1,400 well, if the patient doesn't have a renal failure, doesn't have any hepatic failure, and doesn't have any cardiac failure, which is the average and minimum requirement of water, which can take care of everything. Additional thing would be if the patient is running fever, you can have additional water. If every degree right temperature, over 24 hours, we can have around 100 per day. So all these things you have to keep in mind. How much of that is very important, because I have seen situations where people are given over at the same time somebody worried about regulatory fish and giving more than 4 liters of the take. Apparently to maintain relief. That should not happen. That means that you should have a very clear idea as to how much of the take is allowed for that patient the next 24 hours can. Based upon the things.
So coming to the other general measures, as I said earlier, seizure activity, if at all any, should be controlled because it can increase the cerebral metabolic demand. Also, similar situation is using sedation and analgesia. So which helps to reduce a noxious stimulation that may increase the ICP. So both seizure control, sedation, anesthesia, sedation and analgesia in appropriate situations should be done. For us, BP control.
Radiation, edema, radiation, or manipulation should take up the pain, especially during the patient, right? Aspiration with the through the function, everything has to be taken.
Noxious. And for BP control, as I said earlier, we should aim for a cerebral perfusion pressure of more than 60, and we should avoid hypotension at all costs, because especially with hypoxemia, it can induce vasodilatation and raise the ICP again. And pressors are considered safe. There are no studies showing that pressors are contraindicated. And in raised ICP, almost all our routine inotropes can be used. Now, next coming to the main aspect, that is hyperosmolar therapy. So there are 2 components of its mechanism. The first one was what I told earlier. Suppose we create in cytotoxic edema, what happens is there is sodium inside the cell, water moves in and the cell swells up. So if we make the blood more hyperosmolar, that means that water will go out of the cell back into the blood, and it results in brain dehydration. So this is the main mechanism that is shown in this picture. This is how hyperosmolar therapy works. There is also a second postulated mechanism, is that it reduces the blood viscosity, which improves the microcirculatory flow. So once all this microcirculatory flow is maintained, there is a compensatory constriction of the small pile arteries, which so this vasoconstriction.
When it becomes hyperosmolar, how it will become very explosive.
Oh.
We have seen that polycythemia and when the hypertoxemia or blood will become more viscous that things and then will get a hyper.
Water comes into the cell.
Theoretical point.
Yeah, when water is drawn into the blood, it reduces the viscosity.
I have noted with the electrical.
So what are the available treatment options for hyperosmolar therapy? They include hypertonic saline, mannitol, and historically we were using glycerol and urea, which is not being used now. So we'll look into all of these. So for hypertonic saline, ideally was what we commonly use is a 3% saline, and the mechanism is just what we described. It makes the blood more osmolar and water is drawn in from the swollen cells. So how to give it? Actually, different institutes.
Very clearly, when you are giving hypertonic saline, the intravascular osmolarity will increase. That will create an output gradient, which will facilitate an escape of water from the interstitium into the intravascular compartment. Okay, so water is getting taken from the pancreas into the intravascular compartment. That is what it is doing. It's clear.
So various strategies have been described, which are followed in different institutes. Some people prefer a bolus therapy, some people prefer an infusion therapy, some people prefer a combination therapy. We'll see some of the studies and evidences which are available for this. And also some of the adverse effects also we should be knowing, which includes hyperchloremia, and definitely as we are giving fluids, there is a risk for pulmonary edema also. So how do we calculate?
At this point, which you need to understand is that the utilization of 3% saline for this indication is totally different from how you use it for a chronic hyperactivity infection. Okay, so here we are trying to reduce a hyperosmolar state to facilitate something at the shortest time possible. It's not like a calculated correction over this 24-hour stay, like what we do in chronic hyperactivity infection. That point has to be clearly kept in mind. Okay, what are different?
So for calculating the infusion rate, we use the same formula which we use for hyponatremia correction. That is deficit into weight into 0.6. And we know that 1 liter of 3% saline has 513 millimoles of sodium. So based on that deficit and how much we need, we can calculate the infusion rate also. So we can give either as a bolus therapy or infusion therapy. What we normally do here is we give around maybe 25% as a bolus over 1 hour, and the rest of it we can give as an infusion. So what are the clinic pitfalls we commonly encounter? So as Sir said, this formula works well only when all of the other parameters are in a physiological state, because that formula is for hyponatremia correction. So it doesn't take into fact that many of these neurological cases are complicated by issues such as cerebral salt wasting or SIDH. And there is many alterations in the blood vasculature also. Suppose there are coexisting renal or endocrine conditions also, they can also alter the physiology. And suppose we are giving mannitol along with 3% saline, mannitol can lead to both urinary water and sodium loss, but we cannot really predict how much water or how much urine is lost by mannitol. Hence, when we give it together, our correction may not always reach our targeted.
Mannitol, the hyperosmolar area, can afford peripheral hyperosmolar. So it will be holding water, it is sold by dependent on sodium. Okay. So all hyperosmolar can probably load to pseudo hyperosmolar. So that will increase the calculation. That also has to be
Kept in mind.
Another question.
So the bottom line is this formula-based correction may not be always accurate. So the best we can do is initial stages, we can, after starting osmotherapy, we can check the sodium more frequently. And once it is stabilized, we can calculate every 6th or 8th hourly. Thing is, like each time we calculate and adjust the infusion rates accordingly, it can lead to a better achieving of our targets. So that is what we can do from our side. And there are multiple factors intervening. And again, this is one common issue which we have. I won't go into the details. Just both of them will look similar because urinary sodium and urinary osmolarity will be increased in both. However, clinically, we can differentiate based on the fact that patients with
Gradients is a hypoosmolar hyporetic state. In that state, what the body is supposed to do? It will excrete more of a diluted urine. And because of the endocrine failure at this point, we will be getting a concentrated urine. Paradoxically, you will be losing sodium to the urine. Okay. So that is the discriminated point. So your patient need to be urinated. And there has to be no other factor which could account for the low sodium. So it should not be, there should not be any dehydration. There should not be any concomitant diuretic usage. There should not be any renal dysfunction. there should not be any clinically over hypothyroidism or any other endocrine failure. Okay, all medications are important. All coexisting medical conditions are important. When these things are not there, a hypovascular hyponatremia, and when there is an inappropriate expression of sodium to the urine, as evidenced by a poor urine sodium, for that will suggest an stage. If you would like to confirm, the shortest point you go for a urine sport sodium. Okay. So management should not be deferred because in this given context, it is a serious error.
So just one point to clinically differentiate.
The fact that she would like to describe in detail because the other entity which can closely mimic this kind of a problem where your sodium expression is paradoxically on the higher side can happen rarely in cerebral salt wasting. So that is that expert you would like to differentiate it. So how you differentiate?
So clinically, the patient will be dehydrated in cerebral salt wasting, and secondly, one
What happening in cerebral salt wasting?
that sympathetic drive to the kidneys is lost. Sympathetic drive to the kidneys is
Generally activity.
the sympathetic drive to the kidneys is lost, and there is decrease in the renin, angiotensin, aldosterone system function. So there is decreased reuptake of because the signals come from brain. Sympathetic drive. And one more thing we can check is the fractional elevation excretion of urate, which is more in cerebral salt wasting. That can be used to differentiate them. So again, some more practical aspects is we should not increase more than 10 to 12.
Cerebral salt wasting can happen severe brain injury. And usually that is rare. Clinical proof will be the patient will be dehydrated. So if we had a patient with a hyponatremia, you would start with medicine or personalized.
So some other practical aspects do not increase more than 10 to 12 milliequivalents in 24 hours because there's a fear of complication that is.
No, the thing that every week. You don't have to dedicate it for that.
So obviously for chronic cases, we should adopt a slower infusion strategies. And most importantly thing is like we should not abruptly stop the infusion. We should ideally taper and bring it down. So even if in a stroke case or any other case where a surgical decompression has been done, again, it does not mean we should abruptly stop the hyperosmolar therapy.
That is very important. Never be under the pseudo confidence that when the decompression has been done, everything is taken care of. It cannot be like that. So you should know how to assess the efficacy of the decompression procedure by looking at the cost of scans. How do you know that the decompression is or not?
There is opening up of all the cisterns and there.
You have to see how much of one has been taken under posteriorly. The average intestinal it has to at least 1 centimeter. You can measure. And then next you look at the neuroplasty. Neuroplasty is open. Should not be closed tightly because it has to yield outside towards outside. So if it is bulging outside, you can tell that the neuroplasty is lax. And whether brain matter is able to bulge out or not. Sometimes these may not happen. Just a surgery and everything tightly closed. Then there is no use of doing it. So first of all, you should see the positive scan to assess the adequacy of decompression, which unfortunately many people are not doing. And then accordingly, you have to decide how I need to modify the anti-edema measure, how aggressive I need to be. Then many times you have seen that the delayed, maybe after a week or so, delayed reaccumulation of edema, and both in infarct and then in pre-edema, leading on to catastrophe. That we have seen very dead. That is also abrupt sloping without monitoring. Because you do not know this kind of hypernatremia tendency is going to last for how long. Each patient is different. For some people, it may be lasting for many weeks. So therefore, we need to be very, very careful. So we will be under the pseudo confidence that okay, decompression done already 1 week after decompression. Now nothing happens. So we have seen situations where patient people going for a delayed edema development, either going for a decompression again or leading on to bad outcomes there. So both in bleed and in blood. So the stopping and tapering is extremely important.
So this was a systematic review which showed the use of hypertonic saline in acute infarcts.
So we won't look into all of these studies in view of lack of time. So some of the things we can see is that the targets which they used in most of them was 145 to 155. And in this study by Larry, they showed that in the initial few days of infusion therapy, there was a direct association between sodium concentration and the GCS score. So thereby highlighting that it definitely has a role. But what they concluded, what the author's conclusion from the review was that the data supporting the use was limited. And even though the reported studies demonstrated an improvement in ICP, there were no significant differences in the functional or neurological outcomes. But the thing is,
it is heterogeneous kind of situation, and you don't be able to randomize because you have a very, very grossly altered physiology, gross pathology. It's already in the gross pathology. So whatever is going to control the gross pathology and make it closer to the normal physiology, to the probably will help. There is no room for just leaving it, telling that there is no evidence. But the physiology is grossly altered, amounting to gross pathology. You have to bring it back.
so one of the things we can infer from this is the duration and target. So most of them kept a target of 145 to 155, and the range also what we see is it's not a very small range. It is from 1 to 17 or 4 to 23. So thing is like the duration of hypertonic saline infusion should be tailored according to that clinical situation. We cannot just give for 1 week and stop, or 2 weeks and stop. Based on the clinical profile, we have to continue for as much as needed. So whether to give bolus or
Not well, you say. It was said, which was 5 years dead. Later. Anyway.
So whether to give bolus or infusion, again, there is not much studies based on this. There was one which compared the both in traumatic brain injury patients, and which showed that the continuous infusion was more successful for achieving the osmolality. However, no difference was seen in the other aspects. So maybe infusion therapy might be a bit better. Again, we don't know.
No, you have given a situation that one is just one for going for an ankle herniation and expecting brain herniation. So how fast you need to get a hyperosmolar state? As simple as that. It is not like achieving a correct hyperosmolar. So you have to achieve that target or a hyperosmolar state in minutes. Okay. So infusion is going to help you, or bolus is going to help you. So
Based on
you bolus. So you're treating for the impending herniation, a new situation, and you would like to create a ocular gradient. It has to be immediate. You have to create only with the bolus.
So based on the urgency of the situation, initially we may have to give bolus also. Suppose if it's an impending herniation. So after 3% we go to mannitol. So what are the
thing I wanted to tell was that because people have used the 145 to 155, but never get panic. Because your calculation is kind of performed. Either it will understood or overstood usually. Because the physiology is grossly altered. Even if it reaches 160 or 160 to 165, never panic, never correct it with the half normal saline. I have seen people getting correction after overshooting to 162, receiving hyposmolar half normal saline. Should never be done. Why? Because a lot of osmotic currents will further damage all the neurons. This way, then again, the other way, a lot of osmotic currents. That's the damage happening at the cell block.
So after the 3% we go on to mannitol. So what exactly happens when we give mannitol? So first of all, what does 20% mannitol mean? It means that in 100 ml there is 20 grams of mannitol. So what happens when we give 100 ml of mannitol? What happens is soon after administration there is a transient increase in blood volume. You give 100 ml mannitol means 100 ml there is increase in volume. So this raises the cardiac output, and which can theoretically precipitate pulmonary edema. Also, this increase in cardiac output results in an increase in the cerebral perfusion pressure, and provided the autoregulation is intact, this elevated CPP will lead to cerebral vasoconstriction and thereby diminishing the cerebral blood volume and ICP. So this is what happens immediately, and it is not due to its hyperosmolar effects. The hyperosmolar effects usually takes a bit more time. What happens, it promotes the shift of water from the intracellular to extracellular compartment, as we saw earlier in hypertonic saline, and excretes it via urine, and that also results in a further reduction in ICP. So it has two effects. Initially is the non-hyperosmolar effect, and later on the true hyperosmolar effect. So this is how mannitol works. Regarding the dosage, what we recommend, what is recommended is 0.25 to 1 gram per kg given over 20 to 30 minutes. So for urgent reduction, we can go up to 1 gram per kg, and the bolus is repeated every 4 to 6 hours. When we give mannitol, the ICP reduction occurs within 5 minutes with the peak effect at around half an hour to 1 hour, and the effects last for about 1.5 to 6 hours. And the side effects we should anticipate are, as I said earlier, there can be a risk of initial decompensation like pulmonary edema, and we should also look for renal failure. And another thing is when we are it can cause some diuresis. So when we are giving along with 3% saline can interfere with our calculations. So again, we look at the literature regarding mannitol versus hypertonic saline. Thing is, in the past few decades, people have shifted more towards hypertonic saline because of its rapid onset of action, such as if we give a bolus, we can have immediate osmolar effect. The effects last a bit longer, and it has an ability to restore or maintain the intravascular volume. And also one of the another theoretical advantages they say is that it is less able to penetrate the brain tissue. And in an already damaged tissue, it does not cause much of osmotic shifts and thereby cannot really worsen the brain injury. That is a theoretical thing. Again, we look at some of the evidences. I'm not going to the details of each of these studies. So most of these studies which showed that hypertonic saline was more effective than mannitol in controlling the ICP. And again, this one by Howard, it was a pilot retrospective analysis where they gave continuous 3% infusion in a patient who did not have raised ICP initially. So what they came to the conclusion was that early and continuous infusion is safe and may lower the frequency of ICP crisis and fatality rates. So early induction in a patient who we think who has is at risk for development of malignant cerebral edema, 3% saline is definitely safe and has a role in preventing the further worsenings. So again, another study which showed that 3% is better than mannitol. However, there are also studies which show that both are similar, both have similar efficacy also. So the conclusion of the systematic review was that
We
while
have to go which is more close to the physiological peak and which is least likely to produce other organisms.
so
And you put all these things together, the 3% saline will have slightly lower than any other reduction.
so the conclusion of this systematic review was that even though some show the superiority of hypertonic saline, both of them have similar effects also. But as I said, it is more physiological to give 3% saline. So it has a slight edge over mannitol. Finally, we look at the HAC recommendations also for stroke,
That's for stroke.
for stroke edema. For what they say is use of osmotic therapy with clinical deterioration from brain swelling is reasonable. They have given a class of recommendation of 2A recommendation. Now, what about the role of loop diuretics and glycerol? Now, as I said earlier, this when we give 3% saline, there is always a risk for pulmonary edema. And similarly, for mannitol also, there is a risk for initial decompensation. Suppose a patient, who's having a cardioembolic stroke secondary to AF or rheumatic heart disease, who's having a history of heart failure. It's not practical to give them any of these therapies. So in such a situation, definitely furosemide has a role, and that can be given a dose of 0.5 to 1 mg per kg. And advantages is it does not produce much of hyponatremia and obviously doesn't cause fluid overload. Something we should check is hyperkalemia. Otherwise, it's fairly safe. Glycerol is used only historically. It has less effect and it's not used now. And regarding this tolvaptan, so some people have tried using it. There is very limited literature. Some people have tried using it in intracerebral hemorrhage as well as in patients with traumatic brain injury also. So they have shown that it helps to increase the serum sodium, and some of them have attenuated the neurological effects also. However, these are early studies only. We don't have too much data on the use of tolvaptan. So for our patient, what we did was initially head and elevation. The initial sodium was 136. We started on 3% saline infusion with a target of 145 to 155, and she was observed for any worsening. So on day 1 following stroke, she had a drop in sensorium during the morning hours. There was a drop in sensorium to E3, V5, M6. And the repeat imaging showed an evolved right MC infarct with compression of the lateral ventricle without significant midline shift. The sodium was 139. We continued the infusion. On day 2, again, the sensorium was the same. The sodium increased to 143. Here we had a pH2 change with 35 cc of bleed and a midline shift of 5.7 mm with an impending ankle herniation. Still, we proceeded with.
Go to the next. Go to the next.
So again, we proceeded with hyperosmolar therapy. On day 3, again, the sodium was 147. And there was a midline shift of 6 mm with maximum diencephalon 11, subpalpal herniation, and subtle increase in edema. Again, we continued it. And when we see on day 5 and day 8, there was more or less stabilization with our hyperosmolar therapy. And at discharge time, she had an MRS of 1 and an NHS of 1 with the full GCS. So this was one case which was managed well with hyperosmolar therapy without the need for going for surgical decompression. So what are the other measures which are which can have a role? First is hyperventilation. What happens when we give hyperventilation? There is CO2 washout resulting in vasoconstriction. So once vasoconstriction occurs, there is decrease in the cerebral blood volume. Secondly, when there is an ischemic injury, there can be acidosis also, which can be countered by the respiratory alkalosis produced by our hyperventilation. Some of the issues is that, logically speaking, when we think about it, when we give hyperventilation and there is vasoconstriction, we are further decreasing the available blood supply to the infarcted areas. So vasoconstriction can decrease the local cerebral perfusion and worsen the neurological injury in the first 24 to 48 hours. And hence should be minimized in patients with acute stroke or traumatic brain injury. And also the effect of hyperventilation is varied and short-lived.
For hyperventilation, it can be downplayed. There are two things. When you have a last part, some areas are being spared by coronal perfusion. Two things are very important. Any increase in ICP will further impair the forward perfusion, and ultimately you will dose the coronal surface area. The second one will be hyperventilation. If you put for hyperventilation, the flow will come down. So if you have hypocarbia, the vascular system is going to be generalized everywhere. You will include the coronal roads. So it will further damage the coronal surface area. So if you want to preserve the coronal surface area, two things need to be properly managed. One is the range sensitivity. Number two, you should not be using hypocarbia. And maybe even if you are using the gastric for minutes. But it's always there a risk of losing the coronal supply area.
So this was some of the evidences. I'll not go into the details of it. So if it was sustained hyperventilation for 3 days in stroke and 5 days in traumatic brain injury, showed worse outcomes actually. And hence, yeah, so it should never be used on a chronic basis regardless of the cause of raised ICP.
Highlighted detection of hypocarbia is the rule.
So again, this is what AHSA recommends for stroke. Brief moderate hyperventilation of a target of 30 to 34 is reasonable as a bridge to more definite therapy. They have not really mentioned how long to give and all. And this was one recommendation from.
Be airlines recommendation, but they did not tell whether to say collateral set risk and some issue at risk, what to do. And situation is not like that, what to do. So it's up to the clinician to decide. If you want to preserve something, you have to avoid this.
So the indications for intubation is same as that of a general case. So when there is a low GCS to airway protection, when the consciousness deteriorates or impending herniation is suspected, in those cases we can go for intubation. The role of hypothermia, steroids, and barbiturates. Steroids are contraindicated as per the HA protocol in stroke because they have been shown to have infectious complications. Hypothermia and barbiturates are not recommended. Again, in stroke, hypothermia was associated with increased risk of pneumonia, hence they are not really recommended. Whereas in other neurological conditions, it has been tried for almost 75 years now. So it may be tried when refractory to other measures. It's not recommended as a standard therapy. There is always a risk for cardiac arrhythmias and severe coagulopathy. The targets and everything, again, it's still unclear. So in refractory cases, may be tried. The role of barbiturates, as I said earlier. Regarding the role of barbiturates in neurological conditions, as I said earlier, it can reduce the metabolic demand and reduce the ICP. Pentobarbital is usually recommended for when we are trying to use it. So it can have a definite role also. And just one thing about the other anesthetic agents. So in addition to barbiturates, etomidate and propofol all can reduce the ICP. Ketamine is known to increase the ICP, and opioid based they can either have a stability, won't really affect ICP or create a slight increase in ICP.
Understanding about those kind of things was important in your marriage. because you have a situation where a subtle change is going to order everything. And things are important. Whether one can have appreciatively given. So muscle relaxation is adequate or not. Whether it is a proper form or a treated in experience. So you should have a general idea about how these things, what is the effect of these medications or lives. So other medication anesthesia was product anywhere pricing.
So ketamine definitely increases the ICP, and opioid waste can have a slight increase in ICP. Whereas reduction, propofol, etomidate, and barbiturates.
And muscle relaxation should be very good.
Adequate.
And the scientific development should be over. Venation should be over.
So we'll just look at one more case also. We'll just rush it in view of lack of time. A 55-year-old with acute left hemiparesis had aspects of 2 with HI2 transformation presented within after 7 hours of onset. So he was started on 3% saline infusion. And on day 1, the GCS was full, had a sodium of 141. Again, had an aspects of 2 with pH1 changes and a midline shift of 7 mm. On day 2, he had a drop in GCS to a significant drop to E1, E2, E1, M4. There was an MLS of 11.2 mm with pH1 changes. There was compression of the lateral ventricles and sulcal effacement with right ankle herniation. So at what point do we decide when to go for a surgical intervention? So this is what AHA recommends. So for a patient who is less than 60 years old, who deteriorates within the first 48 hours, despite our medical therapy, in such cases, decompression, they are given a class 2A class of recommendation. For more than 60 years old, in view of some complications, surgical complications, and rather less good outcomes, they are given only a class 2B class of recommendation. So all this is data. Decompression is a big topic. We will not go into details of it. So most of this data comes from these 3 trials in the late 2000s, which were conducted in Europe, which all showed a positive improvement of decompression following stroke. And there was a pooled analysis of all these studies, which showed that surgery with decompression created a significant reduction in MRS scores, and the survival was also increased in patients who underwent decompression. So these were all these studies. All these studies were on patients less than 60 and more than 60. Also, there was a Destiny 2 trial, also showed some improvement. So when to go for decompression? So there were very early studies which showed that within 24 hours, if it's done, it showed very good improvement. But that is a problem because we cannot always predict when a patient will develop significant brain edema. So always such a surgical procedure can have its own complications. So if we intervene early, we may put the patient at risk for such issues. Later on, we have studies which show that 47 to 48 hours, if it's done, it shows a better outcome. So currently, what they recommend is within 48 hours. So, but the thing is, the final decision must be made after weighing all the pros and cons. The comorbidities of the patient, the expected complications from the procedure, all should be considered before making a decision. So for our patient, what we did was we intubated and mechanically ventilated. Head and elevation was done. Hyperventilation was done for target PCO2 of 30 to 34. And on the same day, he was taken up for decompression. This was the post-op images. It was sedated E2 VTM1, midline shift of 9 mm, and the sodium. The thing is, hyperosmolar therapy was continued. The sodium was 149. Day 6 also, sodium of 146, pH2 changes, and sensorium actually became full, E4, V5, M6. At discharge, had a GCS of full GCS with an NHS of 9 and MRS of 4, and 3-month follow-up had an MRS of 3. So this was one case which was managed well with decompression as well as with 3% saline also. There's one more short case. This was a patient with insidious onset right-sided weakness, and the MRI is very clear of a space-occupying lesion with significant vasogenic edema. So what do we do in such cases, in addition to what we already discussed? So this is just to discuss the role of steroids. In patients who are having symptomatic peritumoral edema, systemic steroids should definitely be considered. And which one? Most of the guidelines recommend dexamethasone because of its high potency and because of its relative lack of enterocorticoid activity. So also you can easily convert it from oral to IV with a 1:1 conversion ratio. Who require low dose of dexa, we can try prednisolone. Dexa is always recommended. This is the guidelines which are from up to date. So when we're deciding whether to give IV or oral, first thing to see if there are any symptoms due to this peritumoral edema, such as headache or something, and if there are signs of impending herniation. If there are signs of impending herniation, it's always better to go for a IV treatment, that is 10 mg IV followed by 16 to 40 mg per day divided dosage. Suppose there are no signs of impending herniation, and if you want to initiate steroids, if the symptoms are mild, we can go for oral 2 to 4 mg per day Dexa, or there are moderate to severe symptoms, we can go for IV, 10 mg IV followed by a lower dose, 8 to 16 IV. So this is the recommendation, and later on we can taper the dosage of steroids as needed. So when all are steroids indicated in raised ICP, it can be used in conditions where there is brain tumors and CNS infections also. And as I discussed earlier, it is contraindicated in acute stroke. Also in traumatic brain injury, since there is worse outcome, it is not to be used. So to summarize all this, there are various mechanisms for development of brain edema and neurological diseases. And the treatment option should depend on multiple factors. We should figure in many things such as medical comorbidities, what all drugs he is on, what is the urgency of the condition, and various regimens are described for all this osmotherapy and other measures also. Surgical interventions should be decided on a case-to-case basis. So it's not always easy to decide what is the best possible treatment. So it's always ideal to have a protocol which can be used for any ICUs, so that there can be uniformity and standard of care can be maintained. So here we are also recommending a protocol that can be followed in our ICUs for management of raised ICP. So we divided the steps into 4. The step-based general measures that includes the head and elevation, maintenance of euvolemia, and normal to hyperosmolar state, avoiding of free water, including D5 and 5% dextrose and half NS, avoiding hypotension, management of seizures, and sedation and analgesia as in required in case-to-case basis. So regarding initiation of osmotherapy, we should initially calculate the deficit and initiate on 3% saline. Recommended target sodium is 145 to 155, but we don't need to panic even if it goes slightly above. So as I said earlier, we can give around 25% of the deficit as a bolus over 1 hour and the remaining as a continuous infusion. So monitor frequently, initially at least every 4th hourly, and later on maybe 8th hourly. And take care not to increase more than 10 millicoulombs over 24 hours. Mannitol, if we are given, if we are giving, give it at a dose of 0.25 to 1 gram per kg, followed by infusion every 6 hourly 0.5 gram per kg. It's not recommended for chronic use. In cardiac decompensated states, we can go for furosemide also 0.5 to 1 mg per kg IV. And always there are some things we should check while giving osmotherapy, like the initial sodium deficit, and based on that is what our calculation is based on. We should check the renal function, the blood glucose, thyroid function, urine osmolality, and urine sodium. And in select cases, if we are suspecting a chronic hyponatremia, cortisol levels may also be sent. We should look for coexistent diseases, including renal and endocrine issues that can affect the sodium balance, and concurrent medications, cardiac status, all this should be important while monitoring the response to osmotherapy. So as I said earlier, monitor it Q2H to Q4H initially, and once stabilized every 6 or 8 hourly, and watch for features of fluid overload. The step C is the road for surgical intervention. So based on the etiology, we can go for resection, drainage, or decompression procedures. For a stroke patient who is present, especially who's under 60, who's presenting within 48 hours, means early decompression within 48 hours is recommended when there is failure or refractoriness to medical treatment, when there is clinical deterioration or decline in consciousness, or appearance of new brainstem signs of compression. And the important thing is to continue osmotherapy even after decompression has been done. So the other measures, hyperventilation is not routinely recommended. It can be given for some time for when we are awaiting a definite intervention, and the target PCO2 is not recommended to be less than 30. And there is no role for steroids, barbiturates, or hypothermia in stroke. And in very refractory cases, on case-to-case basis, we can try barbiturate coma. Steroids are used in vasogenic tumor edema, the doses which I just mentioned. Thank you.
Okay. So